Hello everyone, thank you for joining us. My name is Kigondu and I am a fourth year medical student from the University of Nairobi. This webinar has been brought to you by MSAKE Kenya with partnership with Daktari Online, RHNK and Scora Kenya. Poverty and gender inequalities contribute to health and healthcare disparities that primarily affect women. During this pandemic, women continue to be disproportionately affected by many sexual reproductive health right issues. There is reduced access to critical sexual and reproductive health services for women, including safe healthcare options during pregnancy, such safe abortion services, prenatal care, trained assistance during labor and birth, and postpartum care. With the mantra of do all you can, while you can, our first speaker is none other than Dr. Simon Kigondu, a stellar consultant obstetrician gynecologist. He completed his undergraduate and postgraduate training from the University of Nairobi. He is the CEO and partner obstetrician gynecologist at Hercules Healthcare, a medical specialist group practice. He is also a consultant gynecologist at the Murang'a County Referral Hospital. To top it all, he is the current Secretary General of the Kenya Obstetrics and Gynecology Society and a council member at national level for Kenya Medical Practitioners, Pharmacists, and Dentists Union. We are truly humbled and delighted to have you, Dr. Kigondu, on board for today's webinar. Dr. Kigondu will be shedding light on maternal health services during this pandemic. Welcome, Dr. Ari.
Hello, am I audible?
Yes, we can hear you, Dr. Kigondu.
Thank you very much for having me on this day. I want to share my screen and kindly tell me if my screen is visible.
Yes, we can see your screen.
Thank you very much. Let me start the. Yes, I want to thank again the team from MSAKE for inviting me. I will try to make it short so that we can have a long interactive session. As you correctly said, I'm a gynecologist obstetrician and the Secretary General of Kenya Medical Association, and we work hand in hand closely with MSAKE to both mentor the medical students. So COVID-19 in Kenya, to date, this was the update for yesterday, had a total number of reported positive cases of 2,216. Of them, males were 1460, and females were 756. The first case was reported on 13th March of 2020. And of these, the case fatality rate has been measured at 3.3%. And COVID in Kenya, the distribution of COVID-19 cases by presentation is as follows. A lot of majority of the people have been reported to have a cough. Others have been reported to have fever. Others have difficulty in breathing, and other symptoms like headache have also been reported. But of note is those three cases where it has been reported as cough, fever, difficulty in breathing. Keep that in mind as we go along the presentation. Of importance is that majority of the cases have been initially reported in Nairobi. The Mombasa cases have also been increasing. Other cases have been reported to be increasing in the border towns of Busia and Namanga. there has been reported cases in Wasingishu who are reporting that majority of them are truck drivers. An important note on this slide is that the key challenge, these were key challenges reported yesterday. Of note is the shortage of personal protective equipment for healthcare workers in sub-national level. Keep that in mind. What are the measures that have been put in place by the government that may affect reproductive health services? Curfews have been put in place. Curfews prevent people from moving from one place to another. There has been a movement of limitation of movements, and there has been a need for personal protective equipment for you to be able to see clients. For this presentation, I did a focus group discussion with a group of obstetricians and gynecologists to get what the situation on the ground is. I also collected hospital data and did interviews and also did an internet survey of the same. The effects, experiences can be described for COVID as COVID in COVID areas and COVID in non-COVID areas. The direct effects of COVID-19 as a disease entity are becoming clearer. The indirect effects of COVID as a result of the measures put in place to control it are also becoming very clear as health services continue. The effects of COVID in COVID and non-COVID areas are similar, but the intensity may vary because the measures taken affect healthcare service delivery in a similar way. For instance, curfews and movement restrictions, both intra-county and extra-county, have in the past stopped both reproductive health service providers and clients from accessing care respectively. The Blue Post roadblock, for instance, in Thika was an example where the medical council had to intervene to provide special passes, like the one projected there, to allow inter-county travel of healthcare workers. Many healthcare workers in Murang'a, for instance, live in Nairobi, and those in Machakos, some live in the river and its environs. These are some of the realities that COVID has to grapple with initially. Some innovative health facilities partnered with police stations to give antenatal mothers curfew passes to allow them to pass during necessity. And plus they also partnered with taxi services, and they also advertise these services on their social media platforms. The closure of antenatal, postnatal, and gynecological outpatient clinics, cervical screening clinics, and family planning clinics, and the CCCs, when COVID was first announced, this was one of the first measures that was put in place. Traditionally, clinics, especially in public hospitals, are areas where large crowds of people may gather. In reproductive health, both antenatal clinics, normal and high-risk clinics, and family planning clinics they all recorded a reduced traffic. The CCCs were closed. Closures of CCCs can result in missed opportunities for prevention of mother-to-child transmission of HIV. In a large facility in Nyanza, one of my colleagues reported that although the antenatal clinic was running, the numbers were reduced. We are now using the focused antenatal clinic model. The challenge of specialized care was low. For instance, cervical incompetence for McDonald's teaching for recurrent pregnancy loss. These services went down. Preeclampsia was difficult to monitor because when you close clinics, this is monitored in clinics. The importance of reduced family planning intake is that there will be an increased number of pregnancies at the end of this. and the deliveries later on this year will be many. This is not necessarily, though, as a result of the closure of the family planning clinics. Many colleagues have reported that several people have come to request removal of family planning methods, such as the coils and the implants, because many are arguing that this being a gap year, where there is literally no business as a result of COVID, then they could as well engage in getting children. Closure of antenatal clinics, both routine and high risk, may translate to suboptimal follow-up. Antenatal clinics have been shown to improve early detections of conditions whose early management prevents bad outcomes. Conditions such as hypertensive diseases in pregnancy, when picked and managed early, can change the course of an illness to good maternal and fetal outcomes. I have seen many antenatal clinics that are missed, and I am wondering if they are missing clinics altogether. One of my colleagues told me. Colleagues have reported an increase in the number of unexplained intrauterine fetal demises, IUFDs, and poor outcomes of pregnancies, who present to hospital very late because they were not going for antenatal clinics. One of my colleagues stated, weirdly, I am seeing a lot of third trimester losses. They are just coming with fetal deaths. Is anyone else experiencing this in their facilities? It is very worrying. To which another colleague replied that, me too, I've actually seen 2 at 42 weeks post-datism. That means they have passed their due dates with intrauterine fetal deaths. These mothers are too afraid to come and deliver. Is it due to COVID? Is it due to curfew? Is it due to costs? I have also seen uncontrolled blood pressures and intrauterine fetal deaths reported another colleague of mine. I suspect that during the COVID-19 season, birth planning will be one of the most important documents we need to propagate. On cervical screening, a colleague reported that although the cervical cancer screening ward and clinics were still open, the numbers were very low, meaning that there could be an upsurge of cancers in the community later. An important aspect of the COVID-19 pandemic is the COVID-19 label. Being labeled COVID-19 could be a death sentence for patients requiring reproductive health services. This label is worse in areas that have been declared hotspots for COVID-19. Fear and stigma by the healthcare workers may lead to a neglect and suboptimal management for patients who need reproductive health services who have been declared COVID. Inadequate personal protective equipment, especially hazmat suits, lead to poor maternal and fetal outcomes. There have been reported cases where poor and maternal fetal outcomes could be traced back to the fear by healthcare workers because the patient had been labeled COVID. Pulmonary edema, as stated there, maternal mortality cannot be reduced to 0. In the West, this is mainly because of high blood pressure, hypertensive diseases in pregnancy, which have since been managed. Now, in this COVID era, the era of PET, or hypertensive diseases in pregnancy, are causing poor maternal and fetal outcomes. PET may cause pulmonary edema, which presents similarly to COVID-19. That is breathlessness, difficulties in breathing, and desaturation on oxygen. A case report, from instance, from one of my colleagues was showed that severe PET got pulmonary edema and got an intrauterine fetal death. There was minimal follow-up during the labor and delivery. There was no reported use of personal protective equipment. Despite all her COVID tests turning negative later, this did not stop her from getting negative outcomes as a result of being labeled COVID. There are many reported cases of suboptimal care. Moreover, mothers may be prematurely discharged from hospitals because the healthcare workers are afraid of the COVID tag. But as you know, their conditions could easily deteriorate. There was a case in Moranga, my hospital, where a mother who was previously normal had a desaturating condition after delivery. The test done eventually turned out that she had a cardiac issue. She had mitral valve regurgitation and mitral valve stenosis, but her presentation was that of had similar presentations with a COVID. So the mother was also traumatized for being labeled COVID, possible COVID, and she required counseling later. That case demonstrated the need for further improvement of COVID-19 preparedness in the counties, where COVID-19 has not yet become a big issue. Failure to prepare for COVID may lead to more fear by healthcare workers, stigma to patients, and suboptimal care that could lead to maternal and neonatal morbidity and mortality for cases previously managed well. One colleague of mine gave the story of a patient with suspected choriocarcinoma who had lung metastasis. And she had a pregnancy test that was positive and lung infiltrates on X-ray. There was a lot of confusion before her management because they were wondering, could it be TB? Could it be COVID? So when she was tagged COVID, she had to be put in an isolation ward. But before she could get further worked up, she developed respiratory distress and needed ICU care. The referral hospitals asked for a diagnosis, and when they were given the differentials, which included COVID, they said that the patient should be investigated first. These delays led to her demise sometime later. As a doctor in the coastal town areas have reported an increase in maternal mortality. The doctor said that we have recorded higher maternal mortality rates in this COVID area than in this other era in the previous pre-COVID 6 months. Is this mortality COVID related? He said yes. Some of the mortalities were antepartum hemorrhage due to lack of transport. Another pregnancy had severe difficulty in breathing, cough that was worsened. A patient was intubated, had a section, but she had a COVID tag. The COVID tag delayed some form of treatment. Another had a cardiac disease and was referred to the big coast province hospitals, and it was reported that she later succumbed to her illness. What about COVID and in labor? What about labor and delivery in COVID-19 cases? A lot of patients are requesting for planned delivery earlier, both by cesarean section and induction. The reasons for these are curfew, transport logistics, and job losses with subsequent losses of insurance cover as a result of COVID-19. Others are requesting for early discharges from hospital for fear of contracting COVID and all the other transport issues above and curfew. Others have reduced night admissions because of movement restrictions. There is arrival to hospitals late in active phase of labor. Others are even requesting removal of implants and long-term methods, as alluded earlier, because this year there is a gap year, there is no business, and some ladies are preferring to have their deliveries this year, while there is no business and COVID has restricted movement. In Nyanza, a colleague reported that patients are delivering in nearby facilities and some at home due to fear of COVID. fear of breaking curfew consequences. 1 week ago, the colleague said they repaired a patient with rectovaginal fistula. That is a communication between the rectum and the vagina, because she had opted to deliver at home. And even that delivery at home, she delivered a fresh stillbirth and ended up with a rectovaginal fistula. The fact that COVID is causing people to arrive late in labor in hospitals, one colleague stated that, I have seen active phases of labor and people laboring from home, but these were early in COVID times. We have had several near misses. Patients are laboring the whole night at home for fear of curfew, and they're arriving in hospital in the morning in advanced labor. Due to the curfew and transport logistics, one colleague of mine gave a sad story of an obstetric case who had what is called antepartum hemorrhage due to placenta previa, a low-lying placenta. She started bleeding at home in the afternoon, got caught up by curfew. There was no transport. Her husband, on the other side, had been locked down on the other side of lockdown. She walked to hospital bleeding, and when she reached hospital, she was in imminent shock. There was no blood. The only blood that was there, she was given as she was awaiting for blood from another hospital. She passed on. Continuing on the blood theme, the lack of blood and blood products as a result of school closures due to traffic is another problem. And there are also travel restrictions, so there are very few donors. This has limited the interventions that require blood transfusions, and it has led to prolonged hospital stay for acute emergency cases such as miscarriages and severe anemia secondary to postpartum hemorrhage. A lot of doctors are doing telemedicine because they are receiving, people are unable to reach them, and therefore we are seeing more increased phone consultations and from clients who are known to the patients. So telemedicine may be on the increase in the near future. Psychosocial stressors are stemming from finances, the lack of finances, which have played a role. Cash paying patients, for instance, and those with limited insurances are visibly distressed when they come to deliver or having reproductive health services. Moreover, there has also been an increased report of gender-based violence. COVID-19 pregnant mothers, a guide, a Kenya COVID-19 reproductive maternal and health guidelines document was developed. One of those documents is to show how we need to manage our COVID-19 mothers, and part of it is that they need to deliver in a COVID-ready hospital. Recently, the first COVID-19 cesarean section in Kenya was done by my classmate and Presidential Uzalendo Award recipient Dr. Wende at Kenyatta University Teaching and Research Hospital. Doing a cesarean section where all theater staff are in hazmat suits is difficult and requires prior planning. These are the new realities of delivery in a COVID-19 situation. But what will happen to the facilities which have no access to personal protective equipment and they are not prepared for COVID-19 patients? These are questions that we need to ask ourselves. The reproductive health services in COVID-19 hospitals, Bagathi has recorded reduced antenatal and maternity visits. The reason for this could range from closure of clinics to stigma of Bagathi being a COVID hospital. Kenyatta and has also decreased due to COVID. Maternity area is in a cordoned off area. The Isili area was due to COVID. COVID testing before referral. It has been challenging that people test patients before they are accepted in the referral facilities. Currently, there are no test kits, they are out of stock, and these can cause unnecessary delays. The necessity for testing for COVID-19 before referral and the lack of testing capability increases the morbidity and mortality due to the delay itself. COVID-19 has also affected the purchasing power of people. Many people have been laid off from work and they opt for facilities where they do not spend any money out of pocket. Many people have closed their income generating activities and many people have their businesses closed. When we go back to, sorry, forgive me for that, private healthcare, the private clients still have access to services, but many do not utilize them for fear of contracting COVID or job losses. On their own, private clinicians have seen many patients canceling reproductive health surgeries, like elective gynecological surgeries. There have been many near misses of patients laboring the whole night at home for fear of curfew. Many people have been retrenched, are on half salary, or have their insurance schemes cancelled. Private clients have access to healthcare, but they are facing an economic uncertainty, and many are threatened by job loss. We have seen large private hospitals reporting that they are taking a hit on COVID-19 and that their numbers of clients for reproductive health services has dropped. They report that their incomes have dropped and many are laying off their staff. Others are taking pay cuts. In COVID-19 areas, some hospitals have added the cost of the PPE to the patient's bill, making it unaffordable. But not all private hospitals are experiencing a low turnout. Health facilities with increased reproductive services are there. Some private facilities have recorded higher deliveries. Their elective cesarean section lists has increased as people move from the other facilities. The possible reasons for this is that some are exclusive maternity units where mothers feel safe. The larger hospitals have reported admitting some COVID-19 patients, and the patients are worried about, so they don't go there. This lends credence to the need for facilities to be dedicated to COVID, while others are left for routine care, especially maternity services. Other facilities may be distance from home, may be one of the other reasons people are going to some facilities. Lockdowns and restrictions of movements may mean that residents choose the facility that is nearest to them. Others are choosing hospitals because they are skilled personnel. The facilities which have a full range of personnel and provide reproductive health services with gynecologists at the lead may get more clients. Facilities where doctors are paid regularly and on time for their work have noted an increase in traffic in private patients. Doctors report shunning facilities that do not pay them for work done. Bureaucracy, hospitals that have less processes and less red tape in booking, admissions, and discharges are attracting more clients in this COVID-19 era. And affordability. It is possible that the facility workload would increase where the cost of reproductive health services would not dent the already dented pockets of families. Where costs are largely covered by insurances like the NHIF, the workload has been reported to increase. The low costs, high volume route may be a big factor in this COVID era. On medical training, the closure of institutions, there has not only been marked by a reduction in human resources for health at the front line, but there is a delay in the training programs that were ongoing. Medical training institutions and universities training doctors were closed, and some of the measures of limiting COVID-19 spread. KMA has argued that medical schools should be open for students to learn. how to manage pandemics in general, and COVID-19 in particular, practically. The institutions, though, must provide personal protective equipment. Internship training is continuing across the country. Medical officer interns are among the unsung frontline heroes, exposed daily to the dangers of contracting illnesses. At Murang'a County Referral Hospital, where I work, I am one of the 2 gynecologists, and interns are the first responders. The quality of care in internship training institution is generally high, as it provides an excellent mix of service delivery, learning, health supervision, and is ultimately beneficial to the clients and human resources for health development for the country. Interns have raised concerns in some areas, and these should be addressed by administration. For MSAKE students, members, we involve them in mental health liaison. Your role is sharing of validated information to the community, organizing and attending these educational webinars, and receiving expert information for dissemination to the community. You can become associate members of the Kenya Medical Association to prepare you for future professional practice of medicine and medical leadership. Kenya Medical Association organizes every Tuesday, in partnership with Kenya Psychiatric Association, mental health webinars targeted at healthcare workers. And you can print your articles on the East African Medical Journal. Thank you very much. I acknowledge the gynecologist who contributed to the focus group discussion and some of the cases that you have heard before. I acknowledge the Murang'a Health Information Officer and all other colleagues who have contributed to this presentation. Thank you.
Thank you, Dr. Kigondu, for the wonderful presentation. I have some questions I'd like to ask you concerning what you talked about. Okay, the first one, is it safe for a mother who is positive for coronavirus to breastfeed her child?
You want me to take that one? Yeah. It is only recent whereby some people, coronavirus, COVID-19 is a new disease. Even the deliveries in COVID-19, and the breastfeeding are being studied currently. There is a paper out now that shows that there is a possibility that breast milk may have COVID-19, but it has not been shown to transmit COVID-19 to the baby. The recommendations for breastfeeding for COVID-19 is that the mother should wear a mask that will prevent the baby from having, for her breathing COVID-19 or coronaviruses, SARS-CoV-2 to the baby. Those are some of the recommendations that are going out there. But the studies are out there about transmission to the baby. None has been shown so far, but 1 or 2 papers have shown that SARS-CoV-2 may be found in milk. So recommendations out there, currently they are breastfeeding with using masks, for instance. But as more studies go on, we will want to see whether we need to heat the milk that has been collected from the mother to reduce the possibility of transmission to the baby.
Okay, thank you. On to my second question. What are some of the biggest challenges that healthcare providers are facing in providing family planning and reproductive health services?
The first challenge that a lot of clients are facing is accessing the health facilities to get those family planning products. As I have alluded to in my presentation, the first thing that was done was closing reproductive health clinics as we were preparing to tackle the COVID-19 pandemic. So on the demand side, the issues that we have raised of curfews, of movement restrictions, mean that the clients cannot actually get to the clinics to get the reproductive health services, including family planning. Secondly, the clinics had been closed so as to avoid crowds. And if you cannot get to the clinics, then it may be difficult for you to actually get the family planning products. Those were the challenges. So there were challenges from the demand side and challenges from the supply side. Yes.
Thank you for the response, Doc. My second question to you is, during this pandemic, are safe abortions classified as essential services?
There are guidelines there are guidelines on the Constitution on what defines on the conditions in which termination of pregnancies can be done. So they are not currently, as I know it, they are not defined as essential services.
Thank you for that, Doc. My next question to you is, what has been the effect of the COVID-19 pandemic on maternal mortality rates in Kenya?
As I have alluded to in my presentation, one doctor in the coastal province has noted an increase in maternal mortality. The areas that are now experiencing COVID-19 pandemic are having an increase in maternal mortality from both what I call direct effects of COVID and indirect effects of COVID. The indirect effects of COVID include suboptimal care of patients who are presenting with signs and symptoms similar to COVID, and therefore, when the healthcare workers are afraid to actually manage them, that may lead to mortality. And one or two of these has been noted. And I suspect that when the history books are written at the end of this year, the maternal mortality will have increased. And this is as a result of the direct effects of COVID and the indirect effects of COVID, where you have healthcare workers who are afraid of taking care of COVID patients. And from my presentation, one of the biggest indirect effects of COVID increasing maternal mortality is in the area of hypertensive diseases in pregnancy, especially PET, because pulmonary edema may actually present in the same way as COVID. And labor and delivery, especially of such patients, requires that you are next to the patient, you are listening to the heartbeat, you are checking, you're delivering. And if people feel afraid that they might get COVID by being near that patient, then some mothers may actually be neglected, and this can lead to higher maternal mortality. So I suspect that the maternal mortality will be higher this year.
Thank you for that response, Doc. My last question to you is, how is the inaccessibility of youth-friendly services being dealt with during this pandemic period?
some of the hospitals have become innovative. And as was alluded to in the presentation, one hospital, for instance, link up with taxi services to allow their clients to actually get passes to be able to navigate their way around the police, to navigate their way around the curfews. And this is, different hospitals are being innovative in that. So passes are one of the ways of ensuring that people get youth-friendly services. The second one is that the facilities in the estates, for instance, need to start giving these services. We have seen in COVID that a lot of people are now using the services of the institutions that are closest to their homes. And one of the ways to scale up these youth-friendly services to ensure that all these institutions and health facilities have the necessary services for that. And that, for instance, would be is what I would advocate for in this period, and also going on forward, because I'm sure in future we will be having pandemics that will affect youth-friendly services.
Thank you so much, Doc, for the wonderful presentation and for answering those questions. We really appreciate the time you've taken for this. Next, I would like to call on Anne to introduce the next speaker. Thank you, Doc.
Good afternoon to you, our dear audience. I am Faith Ann Nyagishugi, a local officer under the underscorer in Kenyatta University. It's our hope that you're doing well and keeping safe. I thank you for making time to attend this webinar as we try to understand the impact of COVID-19 pandemic on reproductive health services. The COVID-19 series is an activity of Medical Students Association of Kenya Student Task Force that has been enrolled in the IFMSA Medical Education System programs in partnership with Daktari Online, Reproductive Health Network Kenya, and Skora Kenya. Unfortunately, we expected to have Professor Joseph Gatheru Karanja, but due to unavoidable circumstances, he will not be able to join us. However, he has sent his apologies. So before I introduce the next speaker, here are a few ground rules. To ask a question, please submit in the Q&A chat box, starting with your name, followed by the organization you represent, then your question and the speaker you're addressing in that order. So I hope you are all together on that. Then I'm now privileged to welcome the next speaker, who is none other than the Executive Director for the Reproductive Health Network Kenya, that is Madam Nelly Munyasia.
Good morning, good afternoon, participants. Good afternoon, everyone. Happy to be stepping in for my chair, Professor Joseph Karanja. As introduced, my name is Nelly Munyasia. I'm the Executive Director, Reproductive Health Network Kenya. And just to thank MSAKE for having us to be part of this conversation, understanding that maternal health is very key to our network. So just to start off, Reproductive Health Network Kenya is a network of healthcare providers across 43 counties, and our main focus is to ensure access to quality, comprehensive reproductive health services. So for this, I'll be talking about something that Dr. Simon has not touched. Of course, we know about the 5 causes of maternal mortalities, and I'm happy that he has emphasized that after COVID, we are going to see an increase in maternal mortalities. And one of the things that I think Kenya has struggled to mention and talk about and even address even continuously as we talk about the causes of maternal mortalities has been unsafe abortion. I will not belabor on the challenges that Dr. Kigondu has mentioned. We all understand that no one had planned for COVID. It was a pandemic, and by the time it came in, of course, we saw a lot of challenges. And access to information, access to services was interfered with. We saw, as an organization that supports, of course, access to safe abortion services within the law and contraceptives, we all understand that in the Constitution, Article 26, we know that abortion is not allowed. However, when the life or the health of the mother is in danger, then a trained healthcare provider can go ahead and provide the services. So some of the challenges that we have been seeing in our network and other actors in this space include we have seen the supply chain being interrupted, and this is because when we had we saw countries stopping flights from coming in, and in country and outside the country, that means that the supply chain was interrupted. Dr. Kigondu has talked about transport, he has talked about curfew, he has talked about masks. We know the girls and women in the communities, these are items that need cost implications. And we've seen people that have also been laid off from their jobs. So that means that access to safe abortion services or access to contraceptives then becomes a challenge. We have also seen situations whereby the very small health facilities that are found in communities where we most of the girls and women depend on these services, they close very early because of curfew. Young people already face stigma going to a facility when there's a lot of people. And most of them, when we were speaking to them, preferred to go to the facilities later in the evening. Now, with curfew and facilities closing at those times, that means that they cannot access services. Today, I was listening to news over lunchtime, and I heard CS Magoha say that we've seen an increase in the number of unwanted pregnancies. And I was just thinking, for me, this is not news. I mean, we've gone through this before. And the sad part is we have not been able to deal with the primary prevention of, unwanted pregnancies. We have shied away from just making sure that we let our young people, we let girls and women know that they can access contraceptives or they can access services when they need them. So I was just left wondering, every day we get a brief on the number of, COVID cases. It is sad that after COVID, we might be dealing with another pandemic. We might have another bigger crisis waiting. And how I wish that the government would also give us a daily figure of the number of girls that are getting pregnant. And some of these pregnancies is not because they're wanted. We have seen rape cases. We've seen people that are staying in houses with spouses that do not need them in those houses. We've seen people that have been raped with even people very close to them. So really, I'm just seated here and wondering, so if we are not going to come in and support and say that, and our government puts in measures in place to make sure that we are providing services to these girls and women, then what happens, next? So as an organization that has providers and we've built their capacity just to make sure that they are able to do the right thing within the law, and make sure that we are helping girls make an informed choice. So some of the measures that we've quickly put in place is, one, we came up with a hotline that is confidential and non-judgmental, where girls and women can call in and get any information related to sexual and reproductive health. If it is rape case, issues of gender-based violence, then we are able to link them up with other organizations such as CRU, FIDA, Kelin, Center for Reproductive Rights, that are providing pro bono legal support for this. Or even refer them to the gender recovery centers where they can get help and get care. We also are using the hotline to make sure that when girls are in distress, when girls are getting, when girls get pregnancies that they've not planned for, and then they are able to speak up to a counselor who either can refer them to a provider to provide services, or they can be, we are also using our providers to make sure that we are offering telemedicine to them. A healthcare provider, we link them up to a healthcare provider who talks to them, is able to counsel them, give them the different options of safe abortion pills, and also provide a family planning method. And this is because we are not providing abortion on demand. We are not, providing abortion as a family planning method, but we are giving it, we are providing options where a girl can make informed choices. Something else we are doing as an organization is to work very closely with the youth peer providers, and we appreciate the role the young people play, especially at this time, just to make sure that they are reaching out to the most vulnerable at this time. Given that they are locked up in the small communities, probably they have no one to speak to. That is when the young people, the youth peer providers come in, and they are able to, talk to them, give them information, refer them to healthcare providers, link them up to other organizations that are providing very key services during this particular period. We also noticed that some of the pharmacies that we were working with, especially to provide contraceptives, also mentioned had issues with stockouts. So it was a challenge, and we used the pharmacy people also as a point where young people could, access family planning contraceptives from them. Young people could go and seek different, seek information with regard to sexual and reproductive health. And the pharmacy people, the pharmacy supplies, or rather the pharmacy points, were able to refer the young women and girls to healthcare providers for services. We are also just using our social media platform to create awareness to girls and women, especially during this period of COVID, so that we are not leaving anyone behind. We are making sure that sexual and reproductive health are a priority right now, and women and girls who are in need of it know where exactly they can access these services. Together with the Ministry of Health, we are also in the process of disseminating the just recently developed Kenya COVID-19 RMNH guidelines for our healthcare providers to appreciate and understand what do they need to do to either a pregnant woman, a woman that is in need of post-abortion care, a woman that is, has been sexually violated. What do they need to do to make sure that we are not seeing increase in mortality, in maternal mortalities and morbidities? Finally, I think the very important part is just to make sure that we are working with institutions or organizations that provide commodities, especially the family planning. We understand Dr. Kigondu mentioned that there's a lot of COVID stigma right now, and people are scared to go to healthcare, to health institutions. One of the things that came up from our providers when we were just trying to speak with them is that at that point, they had not been trained on COVID-19 infection prevention control. This means that anyone that came to, anyone that went to their facilities, the triage was done, outside the facility. And if you had fever, then you're referred to a government healthcare provider. And this is because at the beginning, when the government started providing information and providing PPEs, they left out the private providers. And we understand very well the key role the private providers play when it comes to healthcare in Kenya. So we have, as an institution, as an organization, we have built the capacity of the healthcare providers just to make sure that just in case they got COVID cases or patients who have symptoms, signs and symptoms related to COVID, then they would allow them to access healthcare from their facilities. So what we did as an organization is we procured for our healthcare providers personal protective equipment. We took them through the COVID-19 infection prevention control training, and just at the beginning there was the whole issue of everyone that tested positive was admitted to the hospitals. And I remember reading on social media, one of the doctors mentioning that it is just a matter of time, and we will see the facilities that are getting these cases will be overwhelmed. And not just yesterday, or I think the other day, we had this say that Mbagathi is full, Kenyatta is full. So really, if we are not going to work together and just make sure that we are building the capacity of all healthcare providers, be it private or public, then it is just a matter of time and we are going to be overwhelmed as a country. So what we have done is work very closely with organizations that supply commodities to make sure that there's a constant supply for family planning commodities and safe abortion commodities, so that when girls and women are in need of them, then they can access these services. And of course, I insist within the law and not, on demand. I think I am done. Unless someone has a question that they need to ask, then I'll be willing to respond.
Thank you so much, Nelly, for that presentation. My name is Ruby Oswera, and we are now going to have a short icebreaker just to, give ourselves a neuron break. So I'm going to be presenting my screen right now. Okay, yes, there we go. So go to www.menti.com and use the code 383416 and answer the poll put there. So if you had the time machine, would you go back in time or into the future? So that's our quick poll for today. Just log in www.menti.com, use the code 383416. This is just a neuron break as we step into the Q&A session, something to yes, okay. I'm seeing we're getting some responses so far. At 50-50. Let's see if numbers will shift. Okay, even as you're answering the question, anyone who might want to tell us why you've chosen the answer that you've chosen. We can also give you an opportunity to do that. Okay, 56, 53. Wow, it's actually 50-50. Okay. 57. The numbers keep shifting. Let's leave it on for a few more seconds, maybe. I see people really want to go into the future. Okay, interesting. I see lots of people want to go into the future. Quite interesting. Okay, so if you would want to maybe tell us why you want to go into the future or into the past, let's just get to maybe 50 responses and I'll give one person permission to tell us your reason why. And then we can go into the Q&A session from the attendees. 23, currently at 65, 35. Okay. So it seems that about 2/3 have chosen to go into the future. If you would want to maybe just tell us why you chose the option that you chose, you can raise your hand and the host will unmute you. Is there anyone who would want to tell us, maybe on audio or?
Yes, hello. My name is Evelyn Odhiambo and I work.
Hi, Evelyn.
Hi. sorry, I work with the Reproductive Health Network.
Yeah.
For me, I chose I would go back in time because
Yeah.
if I go to the future, then that means I'm carrying all the injustices and the inequality, the stigma and discrimination that is current here, and I'm carrying them to the future. So for me, going back in time is actually being able to reset, to sort of like work our behaviors and attitude also when it comes to how we view women and women being able to access services, so that when I'm now going to the future, it's something, a journey that has sort of like, you know, been really realigned, and I can actually relate this to African history. You know, if we go to the future and not understand what the past is actually about, then there's no good you're going to do because you're still carrying on with the inequalities and the injustices back then. So for me, I'll definitely go back in time to settle, make the way, you know, change everything back then to ensure that I'm living in a community that is safe for everyone. Yeah.
Okay, thank you so much. Thank you, Evelyn. Thank you for attending and telling us what your preference is. Is there anyone who'd want to go into the future? Maybe you can tell us why. Anyone, just raise your hand and the host will be able to unmute you. Because we've gotten one side of the story, so let's see. All the people looking to go into the future, maybe you can tell us why, which is the majority, coincidentally, about 2/3. Is there anyone? Do we have anyone? You can just raise your hand, and I believe the host will be able to unmute you. Do we have someone? Hello, hi. Hello.
Yeah.
Can you hear me? Hi, how are you?
Hello. Fine, I'm Lois.
Yes,
And
welcome.
I will at least go to the future. Because
Why?
everyone living in this kind of pandemic is hoping for a better future and a place, a time when this pandemic will be over. And I think into the future, if we believe it's over, we'll get to discuss some things like the effects of COVID-19 to our sexual reproductive health.
Awesome. Thank you so much, Lois. And we appreciate your contribution. Thank you so much. Okay, so we'll now be taking questions from the attendees. So if you have any questions, I'm hoping that you've submitted them or you are submitting them to the Q&A chat box. And perhaps maybe I can begin with this question from Nancy. She says, I'm Nancy Njeru, a social worker based in Kwale. Thanks a lot for a very informative discussion. My question is, how can the government strengthen involvement of community health volunteers at CHVs in ensuring access to these essential services? And what innovations are in place to ensure that the youth access SRH services amidst the challenges caused by the COVID-19 pandemic? So Prof, if you're still with us, I believe you are, perhaps we can begin with that question from Nancy. How the government can strengthen the involvement of community health volunteers, and also what innovations are in place to ensure that the youth access SRH services amidst the various challenges caused by the pandemic. Doc, over to you.
Ruby, I suppose that's my question?
Yes, it is.
Okay. Community health volunteers are personnel at the level 1 tier of the health system. The health system is structured from the community through to facilities, and at the lowest facility you have the dispensary, then you have the health center as level 3, Then you have sub-county hospitals and county hospitals at level 4 and 5, depending on the services provided. Then you have the referral hospitals at national level, currently Kenyatta, and maybe Moi Teaching and Referral Hospitals. Community health workers are very important component who bridge the gap between the health system and the community. And they are supposed to work in a structured manner. There are Ministry of Health reporting guidelines. Ministry of Health reporting guidelines on what community health workers should report, so as to have a report of what the health at the community is. And usually this is based at the dispensary. So the community health workers are allocated a number of people, let's say 100 people for whom they report, and they are chosen either among from the community, by the community themselves, or they could be selected by the health system, for instance, retired nurses. And currently, there is no formal structure of engagement. And previously, it was thought that the county governments would take up this issue because the county governments are the governments directly in contact with the people. So they should form community health groups, which would be allocated several dispensaries to report to, and they give the health parameters. Dr. Joy Mugambi of Baringo has a very effective community health system. And you probably, one of these fine days, organize a webinar for her to give a picture of what the community health workers are doing there. And currently in the COVID pandemic, the community health workers, I can authoritatively say in Baringo, have been involved by the health teams in actually following up, like for instance, in taking family planning products to specific people who have been, who have registered for those services, and also bringing back information and educating the community on the COVID pandemic. Yeah. So I think that is the role of that. And it is also important for the county governments to empower the lowest level of health facility to provide youth-friendly services. So it is the people of the community to say what they want, and it is the function of the county government to supply the resources to do the same. So the people must know what they want, then the county government can respond appropriately. Yeah.
Wow. Excellent, excellent response. Thank you so much, Dr. Next, I'll go to a question from one of our international attendees. We are privileged to have several international attendees. As you know, our MSAKE webinars are now recognized by the International Federation of Medical Student Associations. So let me proceed to read out this question. Good afternoon, my name is Alo from Indonesia. Hi Alo, thank you so much for being here. I'd like to ask several questions. How are current expectant mothers expected to do antenatal checkups if the clinics are closed? And are all trimesters forbid to visit the clinics? I believe the concern here is like the pregnant women in all stages of pregnancy. So is it like just those in the first trimester or second or third, or is it like all pregnant women who are forbidden to visit the clinics? And is there any specific criteria where expecting mothers can visit a healthcare institution? Yes, Dr. Kigondu, I believe this is also targeted to you, just to, you know, highlight on this issue when it comes to maternal health. What are your thoughts, sir?
Oh, thank you again for that question. And I think we alluded to it in the presentation. But from how we have managed COVID-19 is that initially the advice was that to prevent a spread of COVID-19, then we initially closed the clinics so that structures can be put in place to enable so that when we reopen, because eventually services have to continue, so that when we reopen, then the structures in place, when people come for clinics, they do not get COVID during the antenatal clinics and all. So the access to the clinics was limited for that particular time when the hospitals or antenatal clinics are closed. The structure of the health system in Kenya has many layers. For instance, as a gynecologist, I still see in my office my antenatal clients. So it is not completely restricted. But there are those places, for instance, in the public hospitals where clinics are closed. And if I may use the example of Muranga Level 5 Hospital, the clinics were closed, but from next week, the clinics will be opened with changes in infrastructure, whereby a long time ago, maybe you used to seat 5 doctors and 5 patients in one room, but now recommendations are that we need only 2 doctors, and therefore you need to expand the infrastructure, give more fresh air, screen patients who are coughing not to enter the room. Yeah. So that the period of stoppage was to ensure that you put in place infrastructure to ensure that when you are seeing patients, you are not in danger of getting COVID, and you are also not in danger of spreading COVID to other patients. Other things like personal protective equipment should be provided. Like everyone now during the clinic will be wearing a mask, including the patient, which was not there before. So these are all measures being taken to improve. During this period when there was curfew and limitation movement, as I said, some hospitals even went to the extent of giving their mothers passes, which only I have a pass as a doctor, so because I need to traverse some counties, but people were not allowed to move, but a pregnant mother needs to go to the hospital. So those are some of the innovations that needed. There is also the aspect of, which I alluded to, of telemedicine, whereby the expectant mothers can call, and some hospitals may have a call center, so to speak.
Thank you so much. Thank you so much. You've given us some really useful information, especially when you were talking about, that we need to expand infrastructure when it comes to the social distancing within the clinics. I believe that question has been well answered. Next, this question, I think I will direct it to Miss Nelly. Actually, I think this is your colleague. She's called Rita Anindo. Hi, Rita, welcome. Thank you for attending the webinar. So the question is, my name is Rita Anindo, a youth advocate from Reproductive Health Network. And the question is, what measures have been put to protect the mental health for COVID-19 labeled individuals? Nelly, if you're here with us, I believe you are, perhaps you can tackle this question. What are your thoughts?
Yeah. So thank you once again. Just before I answer Rita's question, I want to add something on to what Dr. Kigondu just said. The guidelines, the Kenya COVID-19 RMNH guidelines also state that we need to have reduced visits to the clinic, at least a maximum of 4. And then also for the pregnant mothers who are going to the clinics, they should not be accompanied. And this is just because of trying to, to reduce as much exposure as possible, especially to people who are not, who do not, need those services at that particular time. And then also, like you mentioned, we are really encouraging that talk to your doctor, talk to your midwife on phone. I mean, visit the facility when it's really, really necessary. And if there's need for you to have the routine, the profiles and the antenatal checkups and all that, then you can always organize on how to be done so that you really reduce the visits to the clinic. Back to Rita's question, I think I've seen a lot of organizations come up with hotlines. We've seen support groups, we've seen psychiatrists, even on TVs we've had the government bring psychiatrists to just talk to people so that they can, you can easily identify if, you know, within your community, within your setup, there's someone who is in distress, and we have hotlines where you need to call. Rita, we are happy to share those contacts so that we make sure that people are taken care of. At this particular time, people are in so much distress because of the reasons that we had, you know, talked about with Dr. Kigondu. People have lost jobs. People, a lot is happening during the pandemic. So organizations have come up and they have support centers where you can speak to a counselor, where you can speak to a psychotherapist, and you can get support when you need.
Excellent, excellent. Thank you so much, Nancy. Perhaps while I still have you on the line, there was a question here. Someone is curious about the Nena na Binti initiative. Could you just maybe elaborate briefly on what it's all about? Is someone who had asked that, yeah.
Yeah, Nelly is my name, not Nancy. So immediately after COVID, we also work with young people across the country, and during COVID, a lot of young people were going through a lot of challenges in terms of just being locked up in a space where you had no one to talk to reach out to. Most of the youth-friendly facilities had been locked, or they could not access the facility for one reason or the other, curfew and all that, the cost that had come with COVID. So when we talk to young people, there was need for them to be able to access a provider, a counselor, without, you know, having the physical contact. And that's when, as an organization, we thought, why not come up with a hotline where young people could, you know, speak to a healthcare provider, speak to a counselor, confide in them, get support without really their identity being disclosed to anyone, without them coming into physical contact with a healthcare provider. So we have seen young people calling a lot, and you can tell that they are going through a lot at this time of COVID. We've gotten feedback after the launch. I think it's been around for now 1 month, and we've gotten feedback because the young people feel that someone is able to help them out, someone is able to counsel them, provide them information, link them up to not only a healthcare provider, but to even other organizations that I mentioned that are providing counseling, psychosocial support, that are providing pro bono services. We have young people that are in marriage and they're going through gender-based violence. You know, they're living with partners that are not as friendly. So it is really diverse, not only limited to safe abortion services, but also linking you up to, you know, any service that you need as a woman, as a girl, during this period of COVID.
Thank you so much for that explanation, Nelly, not Nancy. My sincerest apologies for that. We also have another question here by Andrew Githira. I believe I'll direct this question to Dr. Kigondu. So Andrew says, CS Education has just announced that young girls who would have otherwise been in school are getting pregnant, especially in informal settlements. Do you think increased access to contraceptives should be one of the approaches that the government should be taking to address this challenge? That's a question from Andrew. What do you think, sir? You're still muted, Dr. Perhaps you need to unmute. Okay, no problem, no problem.
So, as I said, in my presentation, one of the methods I used to collect the data and prepare the presentation was a focused group a discussion with fellow obstetrician and gynecologists, quite a lot of them. And specifically one in Kisumu actually said specifically that one of the challenges in this COVID-19 is that once schools are closed and access for them to youth-friendly services has actually stopped due to limitations of movement and schools being closed. So these people are not accessing the health facilities where they are, and therefore not able to access the family planning commodities. And therefore, yes, that would be a challenge. And the challenge is global, meaning that there are many factors that are leading to inability to access family planning services, so to speak. And these include closed health facilities, closed clinics, and closed schools, so to speak. Yeah.
Thank you so much, Daktari. I would like to tell all the attendees that we'll be taking live questions as well. So if you want to ask a live question to Dr. Kigondu or to Nelly, you can just raise your hand and we'll be able to see you. As we await the live questions, there is one here directed specifically to Dr. Simon. This is from Professor Otieno Nyuna. Thank you so much, Professor, for attending the webinar. So the question is, dear Dr. Simon Kigondu, research and programmatic evidence shows that the 5 top causes of maternal deaths in Kenya, responsible for 75% or more of maternal deaths, are hemorrhage, pregnancy-induced hypertension, infections, obstructed labor, stroke, ruptured uterus, and unsafely procured abortion. Why is management not considered an essential service, knowing that in some places it may account for up to 30% of maternal deaths and many more maternal morbidity? Is it a question of head in the sand? What are your thoughts? Oh, sir, I think you're still muted. Perhaps you can unmute yourself.
Yeah, I think webinar etiquette, we usually mute, you never know. You start doing
Quite so, but these are strange times. We'll get used to it. We'll get used to it, yes.
That is fine. Actually, post-abortal management of post-abortal sepsis is an essential service. So this we actually treat in hospitals, and post-abortal sepsis is actually one of the causes of maternal mortality. And the management of this is actually done at the obstetrics and gynecology department. In fact, one of the skill set that interns have to learn is how to manage post-abortal sepsis. So post-abortal sepsis is actually one of the management skill sets that interns do learn. Yeah, thank you.
Excellent, thank you so much. Perhaps we can take one live question. I believe we have, someone's hand is raised. I believe the host can unmute the attendee. There's one hand raised. Yes, and even as being unmuted, maybe I can also mention that we have an excellent feedback form. I'm sure all of you were made aware of the fact that we'll begin to give out certificates to the attendees of the session. So in order for us to, know your feedback from the session, and so that you can also qualify for the certificate, kindly check the chat box for the link. And it will only take you like 3 minutes to fill in the form. So kindly do that even as we continue with the session. Yes. Is there anyone unmuted for a live question?
Yeah, thank you very much. My name is Adelaide, 6th year medical student at UON.
Yes.
My question is directed at Dr. Kigondu. Thank you very much for your informative presentation, and I believe Prof. Nuna's question acted as a great segue to what I wanted to ask about, which is how has healthcare seeking and provision of post-abortal services been affected by the COVID-19 pandemic?
Okay, thank you. Dr. You can unmute yourself. Yes.
Yeah, thank you again. Yes, like all other services, medical, the post-abortal services have actually been affected. And in the presentation and in the focus group discussion that I had with gynecologists, some have seen mothers who have come with antepartum hemorrhage because they are arriving late, and they probably had curfew, miscarriages arriving late, and because they were restricted and all. So the pandemic has actually had an overall effect on health-seeking behavior, which includes seeking services when you're having a miscarriage, or when you're having postpartum hemorrhage or antepartum hemorrhage. So all this is a package. It's actually going together. All reproductive health services are being affected as an indirect effect of the measures that are being taken to manage COVID, which includes both the curfew restrictions, the closing of clinics, unavailability of family planning services, and all. So it is affected in the same way.
Thank you so much, Dr. for that. I would like to take one more live question. So if there's someone with a burning question, I believe the host will unmute you. Yes. Go ahead, sir. Hello, can you hear us? I believe this is Timothy. Can you hear us?
Yes, I can hear you.
Okay.
Thank you. Good evening, everyone.
Good evening to you, sir.
I'm Timothy from Uganda.
Yes.
I'm a fourth-year medical student at KIU. My question goes to Dr. Simon. I would like to inquire, in this period of COVID-19, we've realized that the mothers who are attending antenatal care, their number has kind of reduced. And there are those mothers, mostly in the villages, who have deliberately decided not to come for antenatal just because they believe that COVID-19 is in hospitals, and when they come to hospitals, they will get the disease. So I would like to inquire, which measures are they being taken to address such issues? Thank you.
Thank you, Timothy, for that question. I believe Dr. Kigondu had already touched on it, but maybe you can just reiterate on your points a bit. Yeah.
Thank you, Timothy. And I believe that Uganda also suffered the same fate of movement restrictions, but you'll try to open. But COVID-19, as it were, initially was being managed in the big hospitals, and a lot of people know that they are clients in these big hospitals, and therefore it is only humanly wise, so to speak, that people would interpret that if you do not go to that hospital, the big hospitals, then you are not likely to get it. So even here in Kenya, in the presentation as I made, some of the smaller hospitals actually got an increase in the number of people visiting them due to the perception that the COVID-19 is in the bigger hospitals. So yes, of course, when you hear that there is a disease like that and someone is being managed for it in another hospital, you are likely to avoid it. So some of the measures being taken on this is, one, separation of the COVID patients with the regular health patients, and if it's possible, a whole separation of the hospitals. But if not, then a wing in some hospitals has been dedicated to COVID, and others continue with other services. And the other one is to educate people on how COVID is spread, so that even if they think that there might be someone with COVID in a hospital, they will not necessarily get COVID by just being in that particular hospital.
Excellent, excellent. Thank you so much, sir. Perhaps just as a parting shot, I've just seen an interesting question that I believe would be suitable to end this session with. This is from Lois Aching. Excuse me. And the question is, how can the medical students be included in the fight against COVID-19? How can the medical students be included in the fight against COVID-19? We have very many students on this webinar, so we are curious, what can we do to help the situation?
So before Dr. Kigondu speaks about the students, can I go? This is Nelly.
Oh, yes.
Yeah, so before Dr. Kigondu speaks about the medical students, I wanted to say something to our colleague from Uganda. One of the strategies that the government has also put in place is use of the community health volunteers in identifying the pregnant mothers and making sure that they access antenatal care. And of course, also, they are very key at this particular moment in ensuring that they provide the most relevant information and just understanding how COVID is spread and what they need to do as pregnant mothers. I know at the beginning, we also saw mothers scared, and we saw, actually there are 2 or 3 that died because they couldn't access the healthcare facilities, but the government is using the community strategy to make sure that the community health volunteers are very key in making sure that pregnant mothers still access care. Over to you, Dr. Kigondu.
Thank you for that contribution, Nelly. Thank you. Thank you. Over to you, Dr. Ray.
Yes, as I said, I'm the Secretary General of Kenya Medical Association, and we take medical students as associate members. And then when you become a doctor, then you become a full member. Associate membership can be, you can register on our website using you can look for the KMA website or register in portal.kma.co.ke. That's one thing. Being affiliated to your medical association, and then the CEO has various activities that medical students can occur with. Traditionally, they have participated actively in our conferences. They also help around. But now in COVID-19, with this information that you have, you should act as actually the community health workers. You're the people who should be teaching your communities. You're the people who should be teaching your communities what COVID is. Using these webinars, I think you've learned a few things. You are the people on the ground teaching. You would also try to get involved in learning how to manage pandemics, because when you finish, some of the opportunities, including becoming epidemiologists, including managing disease and becoming leaders in the associations or organizations that you'll be leading to be able to manage this. Because in future, there'll be many pandemics, and therefore, these are learning opportunities for students. It's also a time maybe to interact with your seniors. You can volunteer in health facilities while you're out, let's say. And also more importantly, you should be reading and reading and reading more so that you're knowledgeable to be able to apply these lessons that you have learned in the pandemic in future.
Thank you so much for that parting shot, Dr. Kigondu. We really had an informative Q&A session, and we truly appreciate your involvement and your commitment towards addressing the current COVID-19 pandemic. I'll now hand over to my colleague, Yasser, to introduce our next segment. Yasser, over to you.
Thank you very much, Ruby. Thank you very much, Dr. Kigondu and Nelly, for the really insightful session. We really appreciate your presence. As Dr. Kigondu says, as medical students, our aim is just to fight the pandemic through health education and, educating our communities at large. In our webinar today, we were supposed to have Professor Karanja from the University of Nairobi. However, he couldn't make it, but he's able to join our webinar just right now, and he would like to say a few words. So without further ado, I'd like to welcome Professor Karanja. To say a few words before we end this webinar.
I have been in another meeting with the Ministry of Health, Dr. Kaliti, a Zoom meeting like this. In fact, I was participating most of it on the road in my car. I have just arrived home, my telephone went dead. So maybe what I would like to say, and I would first of all thank Simon, my colleague, for keeping the fort in my absence very ably, as I saw the last 10 minutes or so of his talk. Let me say that COVID-19 has had a lot of negative impact on the reproductive health care of women and girls. Because of these aspects, which I will just outline briefly in 3 sentences or so. One of them is that the facilities are difficult to reach for women in emergencies because of various things. Sometimes there is misconception that facilities are not accepting patients. Sometimes there is also barriers being put by the police and other agencies along the way. So this creates some of the barriers. There are other barriers because the health care providers have also become fewer, because some are also being put into isolation, quarantine, there is no replacement. Sometimes when they have been on duty for so many hours, they have to take off naturally for a few days or so. So there is that kind of shortage of healthcare providers. However, within the constraints, we are trying as healthcare providers to make sure or to at least alleviate some of these problems by creating systems by which women can access care 24 hours a day, 7 days a week. There are, of course, constraints that are related to the nature of the pandemic, that we have to reduce the number of contacts with our clients, with our patients, We have to reduce movements for our clients from home to the facilities because movements, traveling in matatus and so on will increase the risks of contracting the disease. So these are some of the impacts or some of the challenges that have been brought by COVID-19. But care is being provided in as far as it is possible within the circumstances. We are treating women with in labor, women who have complications of abortion can access care because abortion in most situations is an emergency service. We are still providing family planning, although we are encouraging people who are already on long-acting family planning methods, such as IUD or implant, to extend the time of use by some months, because we know that the effectiveness doesn't just stop when the method reaches its date, use by date. We also are encouraging methods that don't need contacts with the healthcare provider. Use the pill rather than the IUD or implant, use the patch, use the condoms, and so on. And these are being made available more easily than before. So there may have been a question or two you would have liked me to answer. So let me finish there and leave it to questions, since maybe your time is already ending. Thank you.
Thank you very much, Professor Karanja. We totally understand and we really appreciate all the efforts you're doing in order to ensure that the women of our country are healthy and safe. Asante sana. Just because of time, we can only take maybe one question. If anyone would like to ask Professor a question, please raise your hand and the host will unmute you. So I can see Sarah Thiga. Yes, please go ahead. Hello, Sarah? Sarah Thiga, you can unmute your mic. Okay, Nasibo Duda. Hello, Sarah?
Thank you.
Oh, okay. Thank you very much. Hello. Yes, yes, please go ahead with your question to Prof.
Okay. Hello, thank you. Okay, I'd written this question a bit earlier. I'm not sure if Prof will answer it, but I was talking about how breadwinners are going through a lot of frustrated moments, especially because they're unable to provide for their families because of the mass layoffs due to COVID-19. So this is a major contributor to the increase of gender-based violence in homes. So I was asking, is this a good time to continue agitating for more shelter houses to be built in Kenya, where violently abused women could seek help or time from?
Okay, you asked about gender-based violence, isn't it? Our comment was on
yes,
gender-based violence.
Yes,
okay,
yes.
That's one of the areas that we believe has increased during the COVID-19 pandemic, mainly because of the curfew, the restrictions of movement, locked in houses, probably with people that are not part of the family, and so on and so forth. But care for sexual and gender-based violence should be available all the time because we consider it as an emergency. And our guidelines now say that it should be available 24 hours a day, 7 days a week, at all levels of care. Of course, there will be levels of care that will be able to treat more complicated cases than others. But what is recommended is that you give at least first aid and then refer to the level that is appropriate to manage the condition. One of the most important things, especially when it is sexual violence, is that women will need prophylaxis for STDs, prophylaxis for HIV/AIDS, prophylaxis for pregnancy. And this is best given within 72 hours of the incident. So this should be available to women all the time. And of course, where there are injuries, they should be repaired. And for lower levels of care, they should refer more serious conditions to the higher levels of care to be managed properly.
Okay, thank you. Thank you, Professor.
Okay, thank you very much, Sarah. Thank you very much, Professor. I know we have so many questions pending for Professor, but due to time constraints, we cannot take any questions anymore. However, please feel free to email us, any of us, and we can direct your questions to Professor at the webinar. Also, I'd like to highly recommend everyone to fill in the feedback form. I've posted the link on the chat box, so please fill in the feedback form. It's very important. It tells us how we are doing in our series, and it also gives us an insight on who has attended and who hasn't. So please, it's very important. Thank you very much. Feedback is essential. Also, at the end of the webinar, all certificates will be emailed. You'll receive the certificates in your emails after 2 to 3 days. So thank you guys for attending. Before we close the session, I'd like to invite Barbara Nyagi. So Barbara Nyagi is the National Officer for Standing Committee of Sexual and Reproductive Health and Rights, including HIV and AIDS. Some of you might know her from, she was in news the other day from the MHM outreach she did to some communities in Nairobi. So Barbara, the floor is yours.
Thank you, Yasir. Hi, everybody. My name is Barbara Nyaga. As Yasir said, I am the National Officer for SCORA Kenya. So I'm just going to give a short vote of thanks for everybody to wind up this session. So I, Barbara Nyaga, the National Officer for SCORA Kenya, on behalf of the MSAKE Executive Board and the MSAKE COVID-19 Task Force, extend a very hearty vote of thanks to each and every person who has made this webinar a success. I must mention our deep sense of appreciation for our distinguished speakers, Professor Karanja, Dr. Kigondu, and Nelly Munyasia, who have taken the time to educate and inform us on how sexual and reproductive health workers in the country are dealing with the challenges that we are facing in the light of recent events that surround the COVID-19 pandemic. This session has personally been very empowering and enlightening to me. A webinar like this cannot happen overnight. We have been fortunate enough to be backed by a strong team of very motivated and dedicated medical students, namely Atia Tal Munim, my predecessor, Yasir Hamza, the chair of the COVID-19 webinar series, and our amazing moderators, Anne Mararo, Immaculate Chepkemoi, Dangandeep Kaur, and Ruby Oswere. A special mention goes out to Pavranaj Singh, who compiled the webinar promotional video. I cannot thank you all enough for your involvement and willingness to take on the completion of tasks beyond your comfort zone, for the perfect logistic support and guide you have all extended to ensure the flow of the webinar that has gone smoothly thus far. Finally, I would like to take this opportunity to place on record a hearty thanks to the representatives of the International Federation of the Medical Students Association, IFMSA, Reproductive Health Network Kenya, Kenya Medical Association, all those representatives that are present among us right now, all the esteemed doctors and healthcare workers, and my fellow student doctors from the MSAKE family and beyond. Without your attendance, this webinar would not have been a success. And the energy that you have all brought into this conversation is simply one of a kind. Once again, I thank each and every person for your cordial cooperation all through this webinar. I wish you all a lovely evening and a great weekend ahead. Thank you.
Thank you very much. I promise to participate fully in the next event that we shall organize. And I apologize for that extreme lateness.
It's okay, Professor. We are very glad at least you could join us, even if it was towards the end. Thank you very much. We understand you're a very busy man in the country right now, so thank you for all the good work you do. Thank you. As you leave, please don't forget, please fill out the feedback form, and we will be emailing the certificates in 2 to 3 days. Thank you. And if you would like to be attending our webinar, COVID-19 webinar series that is organized by Medical Students Association of Kenya, please feel free to contact me. I've put my details there, and we can be sending you the links to our future webinars in this series as we fight the pandemic through gaining knowledge and educating.
Goodbye, everyone.
Okay,
goodbye, everyone.
Now closing. Okay.